Point-of-care ultrasound in internal medicine by Christian Spanish-Schmidt, MD, hospitalist. Point-of-care ultrasound is an exciting field that gives us a great way to enhance our physical examination as well to help us with many procedures. Here, a brief introduction to it. Here we see how we are teaching medicine today. The miniaturization of ultrasound devices are making it possible to use the ultrasound at the bedside and enhance our findings or the physical examination. Here, for example, we see ascites. The dark material is anechoic and secondary to low density fluid. And you can see white material which is hyperechoic and in this case represent the omentum and the bubble loops. Ultrasound can detect as minimum as 100 cc of fluid in an abdominal cavity. Here in one we can see an inflamed lymph node with normal architecture. However, in two, the lymph node has lost its normal architecture, making it more likely to be malignant and therefore more urgent for biopsy. In here we can see a very abnormal large lymph node with loss of its kidney appearance. In here we can see anechoic pleural fluid and other structures. We can see as few as 50 cc of pleural fluid if we look well. Here a little history. In 1880, the piezoelectric materials were identified. 1940, the ultrasonographic appearance of cancerous and normal tissue is studied. In 1965, the first dynamic ultrasound machine is invented. 1960 to 70 is adopted by cardiologists, radiologists, and obstetricians. 1990, the focus assessment with sonography in trauma is introduced to the emergency department. In 1980, the ultrasound was seen not useful to evaluate lungs. However, as you will know, now this is not accurate anymore. Smaller machines led to more advancement. Now we have the AIOM, and the ultrasound is within the scope of the internist in many ways. Point-of-care ultrasound, however, is not a comprehensive ultrasound study. It takes less time, it focuses on one question, either sign or symptom, and this needs to be disclosed every time to the patient. So it's very important that when you use the point-of-care ultrasound, you should have a question and answer that question with the images you obtain. A question could be, do I need to biopsy earlier than later this lymph node? Take your imaging and make the decision. Some clinical applications, such as procedural guidance, diagnostics, monitoring, resuscitation, screening, are daily uses of point-of-care ultrasound in internal medicine. So everything has a sound, shadow, or acoustic properties. I really like to start always with the sonar. You need to have some imagination when you look at ultrasound and know the shape of the structures you are looking for. Ultrasound works like sonar, sends a sound, pulse, and then waits for an echo. And this gives the shape of the object that is being looked for, after being, of course, evaluated by the machine. In one, we see a boat in the seabed looked from a sonar 2D. Look at the acoustic shadow. You see the tip of the boat in two. In the other picture, we see a bank of fish going towards a fishing boat. How I know this? I know this because I know the context of the picture. In this case, a Doppler from a fishing boat. So it's very important to know the context of the pictures you are taking. Principles of ultrasound. So piezoelectrical materials, when compressed, produce an electrical pulse. So when they vibrate or get a compression from sound, they produce an electrical pulse. And when given an electrical pulse, they vibrate. So ultrasound were creating pulses of sound with electricity, pausing and waiting for an echo that compresses the piezoelectric material, creating electricity that then is converted to an image in the screen of the machine. Frequency and wavelength. So ultrasound waves are about more than 20 kilohertz, but we use 2 to 18 megahertz. It is very important to know that ultrasound can have low frequencies and high frequencies. The frequency is determined by the wavelength. A shorter wavelength will give you a higher frequency and more resolution. A larger wavelength will give you a lower frequency and lower resolution. Each mode has its uses in focus. Then we have pulses of ultrasound that will send the ultrasound into the tissue, and pulses of silence that will pick the signal from the ultrasound to read it. The same way the electromagnetic wave behaves, ultrasound behaves. So the shorter the wavelength, you can see smaller objects, however at shorter distances. The larger the wavelength, you can see larger objects and larger distances. Here we have two probes. One is a phase array probe. This probe has low frequency but high penetration into the tissue with lower resolution. In two, we have a linear array probe which has a short wavelength, great resolution but low penetration into the tissue. This makes one a great probe to see large structures such as the heart, and two, a great probe to evaluate small structures that are superficial such as vessels, to help us with procedures and evaluate lymph nodes. Not everything is easy, however. When looking at structures, certain structures will refract in one direction, specular, and moving the probe to find the correct angle to evaluate the structure is necessary. Other structures may not refract at all the ultrasound, just like a stealth plane don't reflect radar, and multiple angles of evaluation will be needed, and probably multiple probes. Here we have some types of probes. However, these are not the only probes we have. The first one, linear array, is a high frequency, low penetration, high resolution. Helpful as before, evaluation of vessels, procedural medicine, evaluation of skin, lymph nodes. Then we have a curved array, low frequency and scans a larger part of the body. It has low resolution, high penetrance, and is very useful for abdominal evaluations. Phase array probe is a low frequency, but as you can see, the ultrasound comes from the center of the probe, making it ideal to look in between the ribs, and therefore is the probe we use the most to see the heart. It is very important to remember that you are seeing just a millimeter of tissue in a 2D projection, usually. So this is important because you may need many projections and many scans to figure out the shape of a structure. Look at here. This is a transverse scan of the neck. And then we have a longitudinal scan. In the transverse scan, you can see many vessels, thyroid, the sternocleidomastoid, and in the longitudinal view, you see just the carotid artery and the sternocleidomastoid. So in here we can see a transverse cut of the carotid and a longitudinal cut of the carotid. Same here. In the transverse cut, you see a needle in the gel as a small point, and in the longitudinal scan, you can see the needle as a line. The ultrasound works creating contrast within structures. In here, we see a structure that is all isoechoic, and we cannot see any image inside the structure. This structure may reflect in a scattered way the ultrasound, or maybe secondary, that is the same density as the surrounding structures, that we cannot see anything. Then we see a round shape that is darker than the surroundings, and this is called hypoechoic when compared to the material that surrounds the structure. We see then a hyperechoic structure. This structure is round and bright, and it's sending back more ultrasound to the probe than the rest of the media where it is. Last, we have an echoic structure. Usually light fluid looks like that, and this is because it does not reflect any ultrasound back to the probe. All ultrasound probes have a mark. When we are doing body ultrasound, almost always you want your transducer to point to the right or to point to the head of the patient. This changes, however, in cardiac point of care, and the idea is to have a standard. Now we are going to see some modes of the ultrasound. First, we see a parasternal long axis of the heart in B mode or 2D. We can see some structures such as the left ventricle, the aorta and the aortic valve, the right ventricle, the free wall of the ventricle, the septum, etc. This is a 2D representation of a 1 millimeter clot in a plaques, or parasternal long axis. Then we see an M mode, or motion mode, in 2. The operator has set a line or a scan over the anterior leaflet of the mitral valve. To see this in motion and measure the ejection fraction, you can see a snapshot of the movement of the area, in this case showing a normal movement of the anterior leaflet of the mitral valve. You can also see the left ventricle, free wall of the left ventricle, while the operator took the snapshot. This is a very important mode and needs to be understood the full. Spectral Doppler is a mode where you can have a sonogram of an artery or vein measuring the velocity of fluid in the sample vessel. This can be done in a quantitative or qualitative way. Here we see an artery or a vein in the 2D in 1. This vessel has been targeted by the operator and the machine with a line, and the speed of the flow compared to the angle of the probe is shown in 3. This is very useful, for example, in determining gradients or flow in veins after DVT. Then we have color Doppler, which is a mode where you can see the flow of fluid, usually blood, going towards or away from the probe. The color red demonstrates fluid going towards your probe, and the color blue demonstrates fluid going away from the probe. The angle of the probe is very important in here. A 90 degrees angle may not show any flow away or towards the probe. So it's very important to position your probe in the right way to see the flow of the fluid in the structure you are evaluating. Of course, there is an A mode. If there is a B mode, there is an A mode. However, the A mode is essentially a unique line that measures distances. It is still used in ophthalmology to measure intraocular distances. Next, we're going to see the usual movements of the transducer that we use. It is important to know them since you may be instructed to do them while demonstrating your abilities in using the machine. The first one is going up, down, side to side, and it's called sliding. The second one is rotating the probe. The third one, tilting or fanning. And the last one, rocking or pressing the probe. Each of these movements has its own importance in different examinations. As we said before, we need to move our probe in order to find the best angle to evaluate the structure that is below us. See how different positions of the probe will give different echoes towards the probe. Here we have the part of the probe or a transducer, the lens, which is going to give the footprint of the probe. This is the indicator I was talking before, always to the right, always to the head, if you are not doing a cardiac ultrasound. Then we have the body, and then we have the cable or the wire. Usually there is a locking device, and this is universal for all ultrasounds. Last, we have the planes of the ultrasound and are the planes of normal anatomy. We have a median plane, a transverse plane, the coronal plane, a sagittal plane, which is a paramedial plane. We need to know all the planes since different structures need to be evaluated in different planes. Thank you.